Good evening, everyone. Good evening. Welcome. Thanks for joining us on this Hot Topic Clinic. Great to have you on board with us with MB Medical this evening. Thank you for giving up a little bit of your Tuesday evening to join us. So, as someone's already astutely noted, we're traveling back in time to the 10th of September this evening. It's like we're Marty McFly and Doc. Today, I think I'm going to be Marty McFly. So if you haven't met me before, very quick introductions. I'm Neal Tucker. I'm a GP in Oxford, and I do that half the time. And the rest of the time, I work with the MB Medical team, putting together things like the Hot Topics course and this clinic this evening, which is something that's close to my heart because, as many of you may already know, if you've joined me on the podcast before or our previous clinic on IBD, so I have ulcerative colitis, so I have a bit of personal experience. I'm no gastro consultant, don't get me wrong, but I do know I'm a bit of an expert in myself at least. So that goes a little bit of a way. Joining me today is Doc, but with normal hair, not kind of like massive white hair, is Philippa Davies. Philippa, how are you?
Evening, Neal. Evening, everyone. Thank you so much for joining us. So my name's Philippa. I work as a GP. I'm also part of the MB Medical team. I write the CPD modules with MB, and I was lucky enough actually to work with the fantastic Crohn's and Colitis UK. And together we produced 2 free CPD modules based on your inflammatory bowel disease. So I'll post the links for those in the chat. So for anyone who's interested, they're actually really useful for a primary care perspective. I run through all the way through from clinical presentation right the way through to management. I also work with Cardiff University intermittently throughout the year on one of their postgraduate dermatology diplomas. And spoiler alert, there's quite a lot of dermatology in today's webinar. So I'm particularly looking forward to sharing and discussing that with you. I'm your question and answer lady this evening. So any questions that you have on your screen, you'll have a Q&A box. So feel free to type away. You are anonymized. I'll go through the Q&A chat as Neal's talking, and then at intervals we'll pause, discuss common themes and really interesting discussions. So I know there's loads of really great content that Neal's got to cover. So I'll hand back to Neal, and I'll be back with you shortly. Thanks, everyone.
Thank you, Philippa. Yeah, and I should say that this event has been commissioned by Crohn's and Colitis UK. So actually, all the content has been put together out of my evidence review of the subject. Crohn's and Colitis UK. We'll talk a little bit about some of the stuff there at the very, very end, very briefly. So welcome. Thanks for joining us. Why are we talking about inflammatory bowel disease? Because it is an increasingly common problem. So around maybe 1 in 200 people have a diagnosis, will get a diagnosis at the moment, but that is increasing. So the incidence is going up. By the end of the decade, around 1 in 100 will be will be diagnosed with inflammatory bowel disease. Don't really know why that's happening. Someone somewhere, I'm sure, is trying to figure that one out, but it is going to be becoming increasingly common for us and our patients. So you all know the main types: ulcerative colitis, Crohn's. Those are the 2 that we typically focus on. Let's not forget there is also microscopic colitis, particularly in older people. And then when people don't neatly fit into a box, they may have indeterminate colitis or IBD unclassified. But it's a huge, huge topic, and we haven't got time to cover everything tonight. If you missed it last year, it is well worth going back and having a look at our free ND clinic on the diagnosis of inflammatory bowel disease and the management of flares. That's on demand. You'll find that in the dashboard. Just go and take a look at that. It's another quick sort of hour vignette, so it's easily digestible. But tonight, the focus is on something different. So we're talking about extra-intestinal manifestations. So this is the first bit for you guys to do a little bit of work. And I'm going to pose you a question. So you can pop this in the Q&A box. You can do a little bit of typing in that box. Maybe just write down three, it doesn't have to be three, one, two, or three extra-intestinal manifestations of inflammatory bowel disease. What do you think about when we use that term? And have any of your patients presented with one of these recently? And actually, as we go through the evening and we talk about a variety of different extra-intestinal manifestations, be interesting to know your experiences, what you've come across with your patients, what you've found challenging and how they've presented, maybe challenging how we can treat them, and any successes you've had as well. And I'd be really interested to hear from you in the Q&A box there as well. So do get in touch, and let's try and keep this evening as interactive as possible. So, why is it worth thinking about extra-intestinal manifestations? Well, I would argue that it may help us make an earlier diagnosis of inflammatory bowel disease. It may help us avoid misdiagnosis of the problem in front of us. And it can have a dramatic improvement in quality of life for our patients if we do get the diagnosis and they get the treatment that's necessary. So we're going to be thinking about some of the latest research and some of the latest guidelines, as we always do on MB Medical talks. And there's a particularly useful document. It's very timely, in fact, that was published just a couple of months ago, which is this 2023 ECHO consensus. This is the European Crohn's and Colitis Organization evidence review, specifically of extra-intestinal manifestations. And it has pulled a range of experts together from around Europe. They've done a significant trawl of all the research out there and found the best information, hopefully the most up-to-date and accurate information to help us make a diagnosis and then guide on management as well. It is true that sometimes for some of the conditions, some of the data is a bit limited. There may be times where there's a consensus opinion rather than lots of randomized controlled trials and very high quality data on this. But there's also a lot of really good studies out there, and we're getting a clearer picture over time about the impact of these extra-intestinal manifestations. We'll also have a think about some of the other resources, so from NICE, from clinical knowledge summaries, and also some of the stuff from Crohn's and Colitis UK. Now, let's meet our first patient. We're going to have a few patients this evening. This is our first patient tonight, and this is Teddy. He's 23. He comes in with a painful right knee. Been getting worse over a week. Got swelling, erythema, limitation of movement. It's painful when he's trying to weight bear, and he doesn't know why it's come on. He can't think of any specific reason. Yep, he's quite active. He plays football regularly. He's not had any recent injuries, not done anything particularly dangerous or troubling. This just appears to have come on. It's just his knee. No other joints are affected. And he's got no significant past medical history. So in this kind of situation, young person with a monoarthropathy, what would you think is your differential diagnosis? And I mean, all of us will be running through our minds when we see a patient like this about what the potential problems could be. So let's do our first poll question of this evening. And this is very straightforward. In a situation like Teddy's, would you think about inflammatory bowel disease as a potential cause of this monoarthropathy? So A for yes, B for no. And if you're new to these polls, you can just click on whichever button, the sort of the A box or the B box on the screen. Use your mouse, use your trackpad, use your finger if you're on a touch screen, and pop those answers in. Would you think about inflammatory bowel disease as a possible cause of Teddy's painful knee? Now, of course, there is a certain degree of cognitive bias that will be going on when you're answering this question, because, of course, you have all turned up to listen about extra-intestinal manifestations of inflammatory bowel disease. So I'm prepared to have a slight skewing of the data. Nevertheless, it's just a bit of fun. There's often not a right or wrong answer with these polls. It's more about us trying to get a feel for what, just as a collective of primary care clinicians, how would we manage it? All right, let's have a look at your answers. I'm quite impressed. Hundreds of you have They've given up your Tuesday evenings to join us. Thank you. So 2/3 of you would probably not be thinking about it, or certainly not high up on your list. I mean, I wonder. I mean, I probably am in that 2/3 as well. I wonder if I would be thinking, is this inflammatory bowel disease? So half of patients who have inflammatory bowel disease will get extra-intestinal conditions that are linked to their disease. And these can be significant contributors to morbidity, and potentially they can also increase your mortality as well. They're often misconceived. And I think the two main issues here are that sometimes extra-intestinal manifestations will present before gut symptoms emerge. That may be the first sign that your patient has inflammatory bowel disease. So I had uveitis maybe 3 times before I had a diagnosis of ulcerative colitis. This is a common issue. And then also some of them, they occur independently of gut inflammation activity. And I think it would feel logical that you're more likely to get these problems when someone is having significant disease, like gut disease activity. But actually, that's not always the case. So why do people get these? Well, we don't really understand the pathology very well. I did some reading around this, and I'll be honest, I still don't understand the pathology very well. This is not something that's well characterized, but it is realistically an extension of the immune-mediated response. One of the lines I got from I love this in one of the papers. It says there, as part of it, we see association with shifts in leukocyte trafficking. Now, if you know what leukocyte trafficking is, please pop that in the Q&A box and let me know, because I'm still a little bit sketchy on that one, to be honest. I imagine maybe some macrophages going around and just kind of like rounding up all these other white blood cells and then kind of like trapping them in the back of a lorry and driving them from the gut to other parts of your body. But I'm pretty sure that's not quite what's happening. So there's stuff that's going on with our immune system. There's also been shown to be linked with changes in intestinal microbiota. There's also genetic factors as well. There's a whole range of things that kind of interplay together to drive these. One of the interesting things about this ECHO systematic review of extraintestinal manifestations was that it encourages us to consider a broader definition of extraintestinal manifestations and really adopt a more holistic approach when we think about our patients who have inflammatory bowel disease. Because when I think about extraintestinal manifestations, I think about what they term classical ones. So this is the conditions that arise from the inflammatory pathology, but at distant sites. So your arthropathies, your arthritises, your eye symptoms, and your skin issues, and so forth. Many of which we're going to talk about this evening. But they also say, well, actually, maybe we should consider more broadly the other issues that arise if you have inflammatory bowel disease. So there may be consequences from systemic inflammation. So, for example, if you have inflammatory bowel disease, just like with many other inflammatory conditions, your blood is just a little bit more sticky. So you are a bit more prone to getting venous thromboembolism. Also, for various different reasons, you're also more prone to get anemia. There may be a consequence of disease treatment. So, for example, they may be having lots of steroids. They may develop osteoporosis off the back of that. They may get pancreatitis from some of the other immunosuppressive drugs that they're on. And then there's wider associations as well that just seem to be more common in people who've got IBD than in the general population. So, for example, you're more likely to have bronchiectasis and you're more likely to have myocarditis. Why? Is not always entirely clear, but there are some conditions which we classically associate with it. So, a number of these extraintestinal manifestations will potentially present, not always, they can present afterwards as well or recur afterwards, but they can present before people even get GI symptoms. And there's 2 classic groups here. So one is spondyloarthropathies. So that can be either peripheral or axial, and we'll come on to those terms a little bit later. And skin disease, so pyoderma gangrenosum, we'll talk about that later as well, particularly unpleasant condition. I think if we do see these conditions that are classically associated with inflammatory bowel disease, it is definitely worth doing some direct questioning to just do a bit of a systems review and particularly focus on the gut. And you may end up revealing subtle symptoms. It may be that actually it's not predating the GI symptoms. It's just predating a diagnosis. And it may be that you just have a patient who doesn't like going to the doctors. And it took, this is now that I look back on it, this is a terrible, terrible story. It just gives you, I don't know what sort of goes on in my mind. And it probably is a good example of why doctors shouldn't doctor themselves. But it took me almost, it wasn't quite a decade, but it wasn't far off from when I started having some very low level, PR bleeding intermittently to the point where it finally ramped up and my sort of, and the course was set and I had to go and finally address the fact that I had a problem and I needed to go get it sorted. So it may be that you've just got patients that don't like going to the doctors, that don't like the idea of having colonoscopies very much, and would prefer to just bury their head in the sand and hope that everything will just magically go away. As my friend said once to me when I explained that my car brakes were getting bad, he's like, Neal, you know that doesn't get better by itself. It just gets worse till the brakes don't work. I've tried to carry that thought through into medicine now. So direct questioning, you may find that there's some subtle symptoms there. Also, it's true that extra-intestinal manifestations are generally more likely. They are often more severe and they're often more difficult to treat when you have significant gut activity. But there are some that are entirely independent. And this was news to me as well a few years ago. So I don't need to go through this whole table, but the line in the middle, these are conditions that are not associated with IBD activity. And this can also just throw us off the scent when we're thinking about our differential diagnosis. You might think, well, this person's IBD is really well controlled. So if they're getting a bit of joint pain, is it going to be that? Or if their eye is flaring up, is it going to be that? Is it going to be something else that's going on? But you can get type 2 peripheral arthropathies, and we'll come back to what is type 2 arthropathies in a minute. Ankylosing spondylitis, uveitis, all of those, they just happen. They can happen completely randomly in patients. There are others which are definitely associated with marked disease activity. So also some arthropathies, erythema nodosum, episcleritis, mouth ulcers, and equally sometimes the treatment will be try and make sure that you are controlling their gut symptoms as well as possible, their gut disease as well as possible, and everything else will hopefully get a bit better. So if we think back to our patient, Teddy, he's got his painful right knee, swelling, erythema, limitation of movement. We do a systems review where it turns out he is getting some intermittent bowel issues. He's had intermittent periods of constipation in the past, and then more recently, some looser stool. He has been getting some intermittent PR, like low-level PR bleeding. He said, well, it's always stopped, so I've never bothered seeing a doctor about it. He doesn't like coming to see doctors. And he notes that it is all becoming more frequent now. He also has a family history, which he hasn't really put two and two together with, but he's got an uncle who's got Crohn's disease. And all of this builds a picture for you and I that is suspicious for inflammatory bowel disease, and that he probably has an inflammatory arthropathy. So I have not, it's very difficult when you are, when you're presenting to have a look at what's going on in the questions and comments box. So you may have already done this, but I'd be interested to know, have you seen any unusual presentations of inflammatory bowel disease? And if so, do pop them in there. In the meantime, I'm going to hand, I can see you guys have been putting a lot in the Q&A box, it turns out. I'm going to hand over to Philippa. Philippa, what's been going on in the Q&A box then?
Thanks, Neal. Thanks so much, everyone. I must admit there was so much engagement in that Q&A box. At one point, my little fingers couldn't type quickly enough. So thank you. It's so great to reflect on your experiences and really insightful as well. a couple of really key learning points that have come through just in terms of what Neal was echoing, really, in terms of how common your IBD is. So roughly about 500,000 people in the UK currently have IBD. We know that 50% of those with IBD will have I'm going to call them an EIM, so your extra-intestinal manifestation. And actually 25% will have your extra-intestinal manifestation before their IBD is diagnosed. Now, for us, it is such a unique opportunity because if we can pick this up early, we not only improve their quality of life, but also potentially morbidity and for some mortality as well. So it really is important to particularly pick this up early. Someone's asked a really great question. What are the particular risk factors for having an extra-intestinal manifestation? Tends to be 3. So the longer you've had IBD, the greater you are of having an EIM. If you have Crohn's, you're at slightly greater risk of your EIMs, particularly if it affects your colon. And then if you've already had one EIM, your risk is slightly greater. The general themes that are coming through in the chat, Neal, and there's so many, like I said, is predominantly that your EIMs can affect any system in our body. Literally, you can go from head to toe. And, if we start, you can think just from a really brief summary what individuals have popped in the chat. So thank you. It includes everything from strokes to your ocular, oral manifestations, as we've seen with TEDdy, it can cause your peripheral and your axial spondyloarthritis. It can cause lung presentation, so your interstitial lung disease, cardiac, ischemic heart disease, pancreatitis, anemia, everything. So you've got some really, I think real common themes that are coming through. But just for all of you, you're doing such a fantastic job at picking this up early because it's making such a huge difference to our IBD patients' quality of life. Neal, I can carry on all evening, but I'm going to hand back to you because I know there's loads of really interesting topics to continue with. Thanks so much, everyone.
Thanks, Philippa, and thanks for popping your thoughts in. I've seen people have been sharing loads of stuff. So keratoderma, cholangitis. We'll talk a bit about that later. Pyoderma gangrenosum, again, a really grim condition. PEs. Someone was saying about being more curious about the concept of post-COVID multi-organ inflammation. No, they don't talk about that. They didn't really look at that in the ECHO study either. That's a really still remains a very unknown area. And the tendon inflammation as well. That's an important one that could can indicate some kind of inflammatory condition. Now, we are going to have a look at some specific extra-intestinal manifestations. Now, this is definitely not an exhaustive list. We're going to cover the big ones. So we've got things like joint disease, eye disease, skin disease, and blood abnormalities. And just whilst I'm on this, so you may not appreciate this, but one of the really tricky things when we're writing these slides is actually finding useful pictures to back them up. And if you're wondering what on earth is going on with this picture on here, so I basically put into Bing, is it ChatGPT, which is now sort of run, is part of Microsoft Bing. I put into it, please make me a picture of extra-intestinal manifestations of inflammatory bowel disease. And this is what they created, which I think is pretty dark, actually. I mean, there's a tiny skeleton at the bottom, which is weird. And I mean, we appear to be looking at random stuff, including the gut, inside a gut. I don't know. That kind of plays in my head. If AI takes over the world, we're all going to be in trouble. The museums are going to be rubbish. So, right. Let's think about joint disease, because we were thinking about TEDdy and his monoarthropathy. Now, lots of people with inflammatory bowel disease get joint disease. 40% of people will have it at some point, and there's a whole range of ways they can present. So we term them the spondyloarthropathies or spondyloarthritis. That simply means the immune-mediated inflammatory diseases of the joints. And you can characterize them as axial, so more central type kinds of problems. So that might be things like ankylosing spondylitis, which can certainly occur often a bit later on in people's conditions. The characteristics of ankylosing spondylitis, I'm sure we all know, like sort of typically mid to lower back pain, which is typically worse in the morning. You get stiffness. It gradually eases up. It increases over time. It can be increasingly miserable for people. And the key there is if you suspect it, then don't worry about blood tests. I mean, you can do a full blood count and you can do a CRP and you can look for inflammation. Often it will be normal. What they really need is referral for an MRI scan. That is how you make the diagnosis. Then there's also sacroileitis. And this is typically, the symptoms are a bit lower. So you're getting low back pain, hip and buttock pain. And again, you're going to need a scan to confirm that diagnosis. And both of these can occur independently of GI disease activity. Then we've got peripheral conditions, so typically of the limbs. So you can have type 1. I'd not really come across this definitions before, but type 1, which they term as pauci-articular, as in not very many joints are affected. So you get a limited number of large joints that are affected. It tends to be acute onset. It tends to be asymmetrical as well. It does tend to be linked with GI activity. And the good news for people is that often it is self-limiting within 10 weeks or so. Then there's type 2 peripheral arthritis. And this is more like we would consider a classic arthritis, like a rheumatoid arthritis. So you get multiple joints involved. You often get the small joints of the hand involved as well. And this happens independently of GI disease activity. It can last for months or for years if people don't get some treatment. But the good news is that at least now there are a number of treatments that may be effective. So generally top of the list is TNF alpha antagonist. So that's things like infliximab and adalimumab, and some of the other kind of mAbs. Methotrexate, sulfasalazine, and there's a range of biological therapies which may be used in certain situations these days, which is good news for those individuals. One of our colleagues already has pointed out that, because I haven't talked anything about things like tendon inflammation, that kind of thing here, which is also characteristic of some of this. I think if someone's getting recurrent fever, particularly, is it going to be inflammatory? Now, moving swiftly on, next patient is Damien. This is Damien, 35 years old. And he's calling up because he's had 3 days of increasingly troubling left eye symptoms. So he's getting pain. So particularly when he's moving his eyes, so left and right, up and down, that's sore. And when he sees bright light, so as his pupil is contracting and then dilating, then that causes pain in his eye. His vision is still normal. There's no discharge. He has tried some antibiotic drops from the chemist, because lots of our patients do that. They just go, "Oh, okay, I think it's common things are common. I'll try some antibiotic drops in case it's conjunctivitis." We all know that they basically never work for conjunctivitis anyway, because it's probably a virus, but they didn't work for this, and not unsurprisingly. He's tried some analgesia as well, including oral analgesia, which has not been very helpful. And he does have a history of Crohn's disease, but as he points out, it's been well controlled for a few years. So with this limited history, what do you think is the most likely diagnosis? They've got 4 options here. Could it be conjunctivitis? B, scleritis, C, episcleritis, or D, anterior uveitis? Which of those do you think is the most likely option for Damien and his painful left eye? Now, I'm not going to talk about myself all night, but I have to fill in the time when you're kind of clicking the buttons on this. And this makes me think about my own first episode of anterior uveitis or iritis. And again, I must just be in denial. When something goes wrong in my body, I just go into denial. I don't do that with any of my patients. If a patient comes in and says, "I've got this problem," I go, "Oh, right, okay, it's probably this. We better do this." I don't know how my brain works, but I probably left it more than a week with my eye getting increasingly sore, and like chugging down on ibuprofen to try and see if that would help the pain. FYI, it doesn't, and it makes your bowels bleed. So So that wasn't a great move. And eventually I went to the eye casualty, which rapidly diagnosed me and got me on the right treatment. And that sorts you out pretty quickly, it turns out. Moral of this story? Well, I've learned from that. Now I don't wait a week. Okay, lots of you got your answers in. Let's go and have a look. From all that chatting, I feel like I sort of gave the game away. But okay, some going with scleritis, some going with episcleritis, and lots of you go with anterior uveitis. I think that result probably just reflects that, you know what, we don't get a lot of training on eye problems, do we? I mean, in medical school, I spent like 3 days in the ophthalmology department, maybe. Someone gave you one of those prisms that you kind of put up against a slit lamp or in front of a slit lamp against a patient. And they said, try and look at the back of the eye. And you're just kind of like doing this and not having a clue what's going on. Can't see anything. Can't tell them that. Oh, yes, yeah. There's some big festivals back there. I don't know. Anyway, we don't get a lot of training on eye problems. So we are going to think about the 3 most common causes of eye issues linked with inflammatory bowel disease. And 1 in 10 people with inflammatory bowel disease will get an eye-related problem. But if you've not got a diagnosis and you have an eye issue, then it doesn't necessarily mean you've got inflammatory bowel disease. Lots of people can get iritis from loads of other causes. But again, like everything, it just wants to sort of cross our minds a little bit. So first off, let's think about anterior uveitis. This is the most common ocular manifestation. 11% of people, or up to 11%. We'd have to take all these statistics with a little pinch of salt, don't we? Because when you look at a lot of statistics, they often don't seem to add up very well. Anyway, in the paper, it says up to 11% prevalence of anterior uveitis. More common if you've got Crohn's than if you've got ulcerative colitis, but it can happen with both. Sometimes it's recurrent episodes. Sometimes it can be chronic. That means you don't get any more than a 3-month break in between episodes. Keep coming back, and you can get refractory disease, which just doesn't seem to respond very well to treatment. It may be one-sided, it may be both sides. It's usually an insidious onset. So people may have different experiences from mine, but my personal experience is that at some point, you just notice this little niggle, little bit of pain in the eye, and then it gradually increases over the course of several days until it gets really pretty unpleasant. And you might get a bit of redness by that point, but over time, you certainly will get red. After a week, my eye was very red. Photophobia is one because any movement of the iris is inflamed. That's what's happening with iritis. So any movement of the iris, so whether that's accommodation when you're looking at different things or whether that's because it's contracting because of light, that starts to cause pain. And then over time, if you leave it, the longer you leave it, you might then start getting blurred vision. It's also often associated with headaches on that same side. And also you get tenderness of the actual orbit. So when you're kind of squidging your eye around, normally it doesn't hurt at all. But when you've got iritis, when you kind of touch it, then it actually starts being tender, which is not very pleasant. So without treatment, it will continue to get worse and worse, and you start getting scarring around the sort of anterior portions of the eye, and ultimately that can then lead to visual deficits. So speed is the order of the day here. On the day, referral to ophthalmology. They need a slit lamp examination. Firstly, to confirm that there's inflammatory cells in the eye. Secondly, that they need to rule out, and this is why they don't encourage us to start treatment, because they want to rule out some kind of infection on the surface of the eye, so like a dendritic ulcer or something like that, which if you start dropping steroids in it, it's going to get a lot worse. And then you can get some kind of, again, permanent damage of it. So they need to go to ophthalmology. They need to get the diagnosis confirmed, and then they'll get steroid drops. Depending on the severity, that might take 1 or 2 months. And sometimes they get dilating drops as well, first week or two, to try and provide some pain relief, and secondly to try and break down any of those scarring that might have already started forming in the eye. Other eye conditions. So the next one is scleritis. This is much rarer, which is good news because it's really unpleasant. So this is potentially sight threatening, and The classical presentation is of severe eye pain, increasing rapidly over days, nasty enough to prevent people sleeping, again, tenderness of the orbit. You may not necessarily get a lot of redness of the eye, and a lot of the textbooks talk about this kind of blue-violet violet tinge that you can see in this upper image of this person's eye. I mean, would I be able to make the diagnosis off of that? Probably not. Does it matter? No. They're going to have a ragingly painful eye, and the management is clear. You go to ophthalmology ASAP, and they treat it with a combination of NSAIDs and maybe oral steroids, and there's a whole range of other treatments as well if necessary. And then episcleritis. So this is more common than scleritis, and it's a fairly benign condition in the grand scheme of things. So it's self-limiting. It's more likely to happen if you've got active gut disease. So you only get a little bit of redness. You often get this kind of zonal, sometimes like a wedge of redness, mild pain, maybe a little bit of grittiness, and no change in vision. And I've had this one time as well, and I was kind of thinking, what is this? It doesn't quite feel like iritis, which I was very familiar with by that point. And I was very pleased when I found out that it was, when I realized it was episcleritis. And then the order of the day is topical lubricants, cold compresses for a bit of relief, give it some time, and it will normally sort itself out. I guess if there's any doubt in the diagnosis, though, it is very reasonable to get them seen by ophthalmology, of course. Okay, next patient, and this is Lakshmi. She's 28 years old, and she was diagnosed with ulcerative colitis 5 years ago now, and she has difficult to control disease. She's currently on adalimumab, but despite that, she's still getting issues with increased bowel frequency, looser stools, and occasional blood as well. She calls you today because she's got a new rash on her lower legs and on her forearms as well. It's a little bit raised. It's not really itchy. It is a little bit painful and tender. She's got no fever, feels normal in herself, and she emails in a photo. Emails, or that's so old school. She attaches it to her accurate text message, and you can take a look. And this is what her photo shows. So sometimes we often need to be mindful that rashes can be more difficult to see when people have darker skin. But if you look carefully, especially on that right lower leg, you'll see that she does have these multiple, reasonably large red patches on there, and a little bit on the left side as well. So the question is, what is the diagnosis here? So we've got our history of UC, new rash, red patches, little raised and painful. What do you think is the most likely diagnosis? 5 options. So do you think this is a small vessel vasculitis? B, idiopathic thrombocytopenic purpura? C, erythema nodosum? D, erythema multiforme? Or E, pyoderma gangrenosum? Which of those do you think is the most likely option for Lakshmi? Okay, last few seconds. And let's take a look. Here we go. Okay, most of you are going with erythema nodosum. Smart move. So, up to 1 in 5 people with inflammatory bowel disease will develop skin extra-intestinal manifestations. And the 3 main ones are erythema nodosum, pyoderma gangrenosum, and then sort of a mix of orofacial diseases, which we'll kind of briefly touch on. Also worth noting that there's a number of associations. So hidradenitis suppurativa and psoriasis are more common. And then also there's some treatment-related issues that can drive skin problems like reactions to TNF-alpha antagonists and other drug hypersensitivities, and also a greater propensity, partly because of the drugs that people might be on, to skin cancer as well. So we're going to have a look at just the main two. So this is erythema nodosum, and this is what our patient had. You are, those of you who tick that box, you are absolutely right. And it typically manifests as painful red violet plaques or nodules, usually 1 to 5 centimeters in diameter. You most commonly see it on the anterior lower leg. You also can get it on the thighs and the forearms as well. And this is typically linked with gut activity. It tends to be self-limiting. And the good news is, at least it is not scarring. Typically, this is a clinical diagnosis in conjunction with a history of inflammatory bowel disease. But we do want to think about differentials beyond simply IBD, because there's lots of things that can actually trigger this off. So a range of infections, malignancy, certain drugs, including very common ones like amoxicillin and NSAIDs. The contraceptive pill can do it too. Sarcoidosis, a bit less common, of course, but all of these things might also be a driver for erythema nodosum. Usually, the treatment in this group of patients involves controlling the underlying inflammatory bowel disease, and then supportive measures, things like lifting the legs up, compression stockings could be helpful, and perhaps a short course of steroids if it's very painful. And then we've got pyoderma gangrenosum, and this is a really grim name for a really grim condition. Philippa is our dermatology expert here, but the name's a bit of a misnomer, I think, because it's nothing to do with gangrene and nothing to do with infection either. So, but it certainly sounds grim, and that is entirely appropriate, as this is an unpleasant condition. They can be very painful, it can be debilitating, and it will scar. And it starts off with these painful papules or pustules, most commonly on the legs, like you can see on the top picture, often at a site of trauma. And then it can rapidly expand or develop into these horrible, deep, painful ulcers, like you can see on the lower picture here, which is, I mean, it looks absolutely horrendous. So I don't wish this upon anyone. It's sometimes not linked to disease activity. It may predate a diagnosis. So it may be the first indication that someone's developing inflammatory bowel disease. And the order of the day here is definitely dermatology input as soon as possible. Treatment options have traditionally been quite limited, but there is now a role for, again, these TNF-alpha antagonists. They do improve the diagnosis, or improve the prognosis. You and I will not be starting those. That is definitely one for the specialist. And then oral facial manifestations. And the most common one here is mouth ulcers. Quite common in adults, very common in children with IBD. You've also got more, you're more likely to get issues with periodontitis, and then a range of other things which are difficult to pronounce and I don't know very much about. They're usually linked with inflammatory bowel disease. So the order of the day here is in trying to do our best to maximize the control of that intestinal inflammation. And then maybe topical therapies like antiseptic or maybe steroid treatments that may offer some symptomatic relief. I see Philippa's put in something about it's a neutrophilic dermatosis at some point. I'm not quite sure what that's referring to, but I'll come on to that. Philippa, time for some questions. It's all yours.
Thanks, Neal. Thanks, everyone. Thank you so much for everyone's engagement. It's really insightful, and everyone's sharing their experiences as well. So chat is buzzing. So thank you. I'm loving it. A couple of common themes, particularly from the derm perspective. So with your erythema nodosum, people are asking, actually, can you diagnose this clinically? Yes, we can. So it can be a clinical diagnosis. It's a type 4 hypersensitivity reaction to a particular antigen. Essentially, it's where you've got inflammation of the subcutaneous tissue and you get crops of recurrent nodules. So they're subcutaneous nodules predominantly affecting your extensor extensor surfaces of your limbs. So mainly your lower limbs, so your shins and your ankles. They can absolutely be painful, bilateral and tender. They can occur at different sites, including, as with Lakshmi, I think they're on her forearms, but they tend to be smaller. You can also have some prodromal symptoms with your erythema nodosum as well. So just one to watch out for, say fever, myalgia, etc. But like I said, going back to that question, clinical diagnosis is perfect. If there's any uncertainty, you can absolutely, it's our derm colleagues, they tend to take a deep biopsy. So you need to get that subcutaneous tissue. Final point and final question that I loved just about pyoderma gangrenosum, that's the one that's your neutrophilic dermatoses. So I think great question that came through was, are there any particular features with your PG? It's pain that is out of proportion with the lesion that you've got in front of you. So you've got someone that's got a papule or a pustule. If you swab that, it will be a sterile swab. And what's fascinating about your pyoderma gangrenosum is they are so rapidly evolving. So they can grow or they can expand by 1 centimeter per day. And essentially they expand then into the dermis. You get this necrotic ulcer. If you look at the periphery, you get this, they call it an undermined violaceous periphery. And that's really classic of your pyoderma gangrenosum. This is one we want to be picking up the phone or ideally referring really quickly to our derm colleagues because they need their input. Lots that we can offer in between. So wound management. You can offer your really potent topical steroids and definitely analgesia. So lots of brilliant points that are coming through there, particularly for the derm cases. So thank you so much for sharing. Neal, I think I'll probably hand back to you because I know there's lots more to cover and I'll continue on the chat. Thanks, everyone.
Yeah, great. Thanks, Philippa. Great insights into the world of dermatology there. And yeah, thank you just for sharing some of your thoughts from out there as well this evening. So that's fantastic. Thank you. Right, on to our last patient. And this is Sobina. She's 30 years old, got a history of colitis, UC. She takes oral mestalazine to try and help with that. She recently had a mild flare. She presents now with tiredness. So we do a systems review. Her bowels are okay now. She's got no other symptoms of note. We do some blood tests, and she does have mild anemia. Got a slightly elevated CRP. That's a little bit more than is usual for her. And then this is her iron study. So her MCV is 85, ferritin 120, serum iron is 12, and transferrin saturation is 13. So she's got anemia, but what do you think is probably got anemia. What do you think is the most likely diagnosis? We've got 4 options this time. So do you think this is anemia of chronic disease? Do you think this is iron deficiency anemia? Could she have a mixed anemia? Or do you think this could actually represent thalassemia? How would you interpret these findings? And I've deliberately made it quite tricky because it's often quite tricky. Okay, last few seconds to get those answers in. All right, let's take a look. Okay, so half of you going with anemia of chronic disease, some of you going with iron deficiency, some going with mixed. All right, so firstly, let's think about fatigue. This is extremely common with inflammatory bowel disease. Around half of people will get it even when they have inactive or mild disease, and over 80% will report fatigue when they have a marked disease activity. Much more frequent than the general population. I mean, I know a lot of us complain about fatigue, but much more common than on average in our patients, and not even patients in the population. Interestingly, even when people are in periods of deep remission, lots of people still report fatigue. We don't really understand this. There may be some issues around the inflammation, and the treatments negatively affecting a range of things in the body. also brain physiology potentially, and then it can be exacerbated by a range of factors like malnutrition, where we have difficulty absorbing nutrients due to the GI disease, sleep disturbance, and of course, obviously, psychological overlays of having a chronic disease too. But of course, we always want to think, could there be a reversible cause? So we do want to think about, could it be anemia? And anemia is also very common. So it may be iron deficiency anemia. It could be anemia of chronic disease. It could be mixed. The difficulty we've got here is that the markers that we typically think about of iron deficiency anemia are skewed by the inflammation of the underlying disease. So why do you get iron deficiency anemia? So that you get high levels of hepcidin. Hepcidin is important for regulating iron absorption and release from the gut and release in the body. So if you have high levels of hepcidin, that prevents iron absorption in the gut. And when you have an inflammatory condition, that usually it down-regulates it impairs the usual down-regulation of hepcidin. So usually when your iron levels go low, your body goes, okay, let's cut off production of hepcidin, and your iron absorption in the gut will go up, the release of body stores will increase, and everything will kind of even itself out. We go round and round our little iron homeostasis. But that all gets interrupted very badly with inflammatory bowel disease. You see it with loads of other conditions as well, like on the hot topics course, we're talking about chronic heart failure and a whole range of, which is also commonly associated with iron deficiency anemia. Inflammation does bad things in the body. So the reason it may be difficult to distinguish, ferritin levels, which are a normal marker for iron levels, may be normal or raised because of the inflammation. It is, of course, an inflammatory marker. Also, the MCV may be normal in almost half of cases of iron deficiency anemia. So we normally think of that as should be low. And then that promotes transferrin saturation, which is usually way down my list of things that I'm thinking about, as a really good option to try and work out if the patient is iron deficient and is less affected by inflammation. If the result is less than 16%, that supports iron deficiency anemia as a diagnosis. Vitamin B12 and folate deficiencies are also common, especially in Crohn's disease where there's small bowel involvement or if you've had a history of resection. So the guidelines recommend that patients should have a full blood count, iron studies, B12, folate, CRP, and also reticulocytes on an annual basis. Now, of course, in an ideal world, that would be done through the IBD team in the hospital, and hopefully patients are getting annual follow-up. But you and I also know the state of the NHS at the moment, and I'm sure that that's not always happening in all areas. So it may be something that we can think about, particularly if a patient presents and they're symptomatic. Reticulocytes, quick mention about those, because I never really thought about them and I didn't really know why we're checking those. If you've got low reticulocytes, that indicates an inability to respond to anemia. So you're just not making red blood cells very effectively. And there's a whole pathway for how you then manage those patients. That's kind of going into the specialist setting. We just need to know if we see low reticulocytes, then they may need some support with red cell generation. And then, of course, let's not forget the differential diagnosis here. Red flags, are they older? People with IBD can also get cancer. In fact, they're probably more likely to get bowel cancer with many conditions. So particularly if they've kind of describing unusual changes to what their normal symptom pattern is, be suspicious. How do we manage the anemia? The problem you've got is that gut absorption is limited due to those high levels of hepcidin. So IV iron infusion is often the first line treatment. That's obviously going to need to be done by a specialist. In mild iron deficiency anemia, so maybe your hemoglobin is just 11, and you've got inactive disease, then oral iron may be effective. If we're doing it, the recommendations are we check at HB response at 4 weeks and then continue replacement for 3 months after normalization, and then keep an eye on their hemoglobin and ferritin for every 3 to 6 months for the first year, every 6 to 12 months thereafter. And then we've got one more topic, and this is still with soberness. So we suspect she's got iron deficiency anemia because her transferrin saturation is low. We're going to treat her with some oral iron because her mild flare that occurred recently has settled. She's currently got no gut symptoms, and we'll carry on doing some blood monitoring and make sure she's doing okay. And she does get better. Her blood markers get better. Her iron stores get better. Her tiredness improves. But 2 years later, it comes back. She's not got anemia or iron deficiency now. We will think about IBD-related fatigue. And we just kind of park that, and the specialist park that, and she gets on with things. And then 3 years later, fast forward in time now, we're not going back to September, we're going forward into the future. And she has some routine blood tests. And the key abnormality here is an increase in alkaline phosphatase. So what we're thinking about here is primary sclerosing cholangitis. So 2 to 8% of patients with IBD may develop this over the course of their life. It usually starts in your 30s or 40s. More common if you've got ulcerative colitis, you're male, and you've got more extensive disease. And then it's a miserable condition with an average time to death of 21 years or potentially liver transplant. So at least it's 21 years, but that's still obviously far from ideal. In the early stages, you may just get fatigue. A few people might get some right upper quadrant pain, but most don't. And then later on, as you get kind of like more sclerosing of all those biliary the pipes coming out of the liver, then you start getting the blockage, you get the pruritus, the jaundice, malabsorption, and eventually liver cirrhosis and failure. Key indicator for this, raised alkaline phosphatase. So we also want to be doing LFTs as part of those annual bloods. And again, the IBD team should be monitoring this. These patients should be seen in clinic, having this bloods monitored annually. I know locally, more and more patients are being managed over the phone and remotely. And so it's easy for these patients to miss having some of these basic follow-up blood checks. And of course, we don't diagnose it off a blood test. Those patients are going to need to have an MRCP, which is the diagnostic tool of choice. So what can we do about all of this in primary care? Well, the first thing is let's just think a bit more about extra-intestinal manifestations. And if we keep them in mind, that may help us make that earlier diagnosis of inflammatory bowel disease. It may be that this is the initial presentation. So if we see things like non-traumatic arthritis or arthropathy, uveitis, unusual rashes, and particularly if you're seeing them in younger patients that you wouldn't normally expect to have a inflammatory joint problem, probably not gout. You ask the patient, he goes, I haven't had pheasant for a month, doctor. There's a strong chance it's something else going on. Recurrent problems, if they're getting multiple types of condition that could be extra-intestinal manifestations, let's think maybe this person has emerging IBD. And if we keep them in mind, we're more likely to make an accurate diagnosis. Teddy, our 23-year-old, realistically doesn't have a first presentation of gout. And so if we're thinking more about extra-intestinal manifestations, we can get them to the most appropriate person to see them. And then let's think about just making sure they've had those annual blood tests, full blood count, renal function. We want to do renal function as well because there can be renal involvement, and also some things like mesalazine, oral mesalazine. One of the side effects of that, or complications of that, is potentially renal failure. So we want to keep an eye on that. LFTs and CRPs is the basics. We might want to think about those iron studies in reticulocytes as well. And then if we're doing the tests, and let's flag any abnormalities up with the IBD team. So probably the easiest pathway there is to send a message to the IBD nurse, and every area should have one. And then let's do our best to ensure that gut disease is controlled as well as possible. There are some things that are going to be well beyond our level of expertise and well beyond the things that we can prescribe in primary care, but it could be that doing something simple like checking compliance if someone's got UC and they're taking mesalazine. Are they taking it regularly? Are on the optimum dose? Are they on the optimum path? Is oral best? Is a PR route best? let's try and optimize these patients' regimes. Philippa, it's we're coming up to we're smack on 9 o'clock, so I'm sorry I've not left you much time to talk. But any quick thoughts?
Final quick thought that's coming through, and thank you again to everyone that engaged so well in the chat. It's amazing to your experiences. Final thought just with your PSC. So 10% of our PSC patients can actually have normal LFTs. So like Neal said, if we're considering, if we've got someone who we're discussing with who's got pruritus, that intermittent right upper quadrant pain, then certainly worthwhile exploring further so we can do liver screens and ultrasound. It is important with our PSC. Sadly, they have 400-fold greater risk of having a cholangiocarcinoma and a significantly higher risk of colorectal cancer, as well as end-stage liver disease. It can be curative with your liver transplant, but absolutely worthwhile looking into this and obviously referring on to our colleagues. That's everything for me. Thank you so much, everyone. I've had a great evening. Thank you so much to your engagement. Huge thanks to Neal and Daniel as well. I'll be back on your screen shortly, but I'll hand back to Neal to explain more. See you all soon. Thanks, everyone.
Yeah, so final slide then, everyone. So just a quick shout out for some of the work that Crohn's and Colitis UK have been doing. So in collaboration with a number of other UK GI organisations, they've put together a primary care diagnostic tool for lower GI conditions. It's currently in the consultation phase. They're really keen for feedback from clinicians. We want to know if how people in working primary care feel it may be improved or make it as useful as possible for us in practice. There's a very quick survey. We can post the link in the Q&A, and you'll be able to come back and have a look at that if you want. It closes in 2 weeks' time, so do take a look at that. There's more details on Crohn's and Colitis.org.uk. And then a big shout out for our next free clinic. So that is on November the 7th. And Philippa, our dermatology expert, is going to be doing that. And that is on dermoscopy. If you want to know a bit more about dermatology and dermoscopy, then do join us then. And also, she is doing, is it this Friday, Philippa, the Hot Topics in Dermatology course?
It's the nurses course this Friday. So everyone's more than welcome. So can't wait to see you all soon.
Oh, okay. So if you want to know more about dermatology, then Philippa has done an excellent Hot Topics in Dermatology course. You've signed up to MB+. Go on the mbmedical.com website. You'll be able to watch that on demand. Take a look at the website. We'll be doing some more live ones in the not too distant future. Very last thing for me to say, we always appreciate your feedback. When we finish in 30 seconds, you'll see this little icon pop up, which is a very quick survey. We're always trying to improve things based on your feedback to us. So if you've got 30 seconds or a minute, please do fill that in. And it just leaves me to say thank you so much for joining us today. Great to have hundreds of you along with us for the ride, keeping me and Philippa very, very busy for 1 hour. Go and enjoy the rest of your Tuesday night. Word on the street is the Great British Bake Off is on. So let's go catch up with some bread. Thanks, everyone. Night night.